It's always difficult to debate with people when you agree with them a little bit, and it was the case with my debate with Visha, and it's again the case with Mark. And I don't know why I'm always to take the con. There must be something on my face, Leo. You will have to explain me that. And but anyway, it's always an interesting exercise. So I'm supposed to debate against this proposition, which is long-term antibiotics and/or antioxidants are effective. So again, I'm going to use the term useful rather than effective, because utility is not the same as efficacy. I have the same disclosures, and again, I'm going to talk about safety, and Mark usually did talk about safety. So you already saw a slide which looked a bit like this, which is the theoretical background of the effect of macrolides, and actually macrolides obviously have some antibiotics and antiviral effects, but they also have some anti-inflammatory and immunomodulatory, immunostimulating effects, which could explain why they would be useful on the long term, especially for the prevention of exacerbations, not only again through the antibiotic, but through the anti-inflammatory effects. And there could also be some effects which could be of interest with macrolides, is that they could help reversing, at least partly, the resistance to steroids, which is induced by the loss of HDAC I was talking about before. You have several types of macrolides. I won't go into any details on the structure and basic pharmacology of these agents. I just showed you here erythromycin and azithromycins because they are probably those which have been most studied in the literature. And here you see the same as you saw already, which is, sorry, it doesn't work, but which is the meta-analysis which has been published in Respiratory Medicine last year. And you see the effect of macrolides on COPD exacerbations, and as you can see in the last line of the graph, there is a nice prevention of exacerbations with macrolides. So, well, I can't say anything about this specific point, but when you look at some other graphs which are also of interest in this specific systematic review, what you can see here on the top right of this slide is that you have no effect on death, which means that you have, again, a bit like steroids before, you have, again, a nice effect on exacerbations, but nothing on death. And it could be a story of underpower, for example. But the problem is that when you look at the graph itself, you don't see a real tendency. There is a small trend, but you imagine that for this trend to become statistically significant, it would require probably a huge number of patients. So the question again is, why are you preventing nicely exacerbations and even hospitalization, but not mortality? Well, it doesn't say that you don't have prevention of exacerbation, but it does not translate into a survival advantage for these patients. And the other graph which is of interest in this systematic review is the other one on the bottom left, and it's the discontinuations from the studies due to adverse events. And it just shows you that you have, it's not statistically significant, but very close to, you have more discontinuations due to adverse events in the actively treated group, which is logical. When you take a medication, you're supposed to have a bit more side effects than when you take a placebo. But this can be a problem, and you have to keep that in mind when you select the population to which you are going maybe to prescribe these agents, if you believe what has been said, which is that they have some efficacy. Erythromycin. Okay, you saw already this study. Huge difference in the occurrence of exacerbations between the erythromycin and placebo group. That's what you see on the right. And what you see on the left is that there is some background for that, which is the prevention of neutrophilic inflammation, which is illustrated by the decrease here in neutrophil elastase in the sputum. So you have a background, biological background. You have a clinical effect. What do you do with that? You look at the study, small study, 3 times a day, which can be a problem these days. It's an exploratory study, so you should not really take conclusions from that, just raise hypothesis, which has been done, and it's in China. And this is interesting. We'll see why a bit later on. Another study in which Visha was involved quite deeply, so I had some trouble finding flows for these studies. It's my job to find flows, but difficult. Okay. You'll tell us afterwards. But one thing I found here is that there are quite a lot of exclusion criteria, and again, we'll go back to that, especially from the cardiovascular point of view. And, well, it seems that, well, everybody says you have to be careful about cardiovascular QTc and so on. The question is that really a problem? And the answer, you will have it. Make some ECGs to all your patients with COPD. And you'll see if it can be a problem. I don't have the answer. I didn't try it, but do it. You'll see if it's... And the next question is, do you do it? Do you measure the QTc interval to all the patients to whom you prescribed azithromycin? I'll go back to that. Azithromycin. Here are the figures. Relative reduction in the occurrence of exacerbation, 17%. Well, quite good, not too bad, but, well, doesn't translate into any benefit in terms of quality of life. Again, it could be a question of power, maybe. You have no difference in terms of prevalence of resistance, as Mark said, which is nice, but you have a difference in terms of incidence. So, okay, at the end, it doesn't make any difference in terms of absolute numbers in that study, but what will it be if all of you begin prescribing azithromycin? Okay, it's not a problem now because nobody does it, actually. But if everybody does it, you will have the same problem with our COPD as you have with the youngsters that take azithromycin for common colds. That's a bit heavy for an argument, but, well. And people hear less well, and I don't know why actually, but hear less well with azithromycin as compared to placebo, with which actually they don't hear very well too. And the prevalence of macrolide-resistant pneumococci has been studied in other studies in which the figures are very different. Here is what you saw, what you can see in another study published a few years ago, in which the prevalence of macrolide-resistant pneumococci was more than 50% in those who were receiving erythromycin compared to 14% in those who were receiving placebo. So that's a huge difference, which means that the ecological impact could well be much greater than what we can anticipate with the Albert study we just saw. Another problem that could be of importance, at least in some COPD patients, probably not all, certainly not all, is that taking macrolides on the long term could induce the occurrence of resistant non-tuberculous mycobacteria, which can be a problem. It's probably something that it's very much underestimated as a problem in many patients, but it could well be a real problem, these bacteria. And now look at the patients who were treated by azithromycin in the Albert's paper. Here you are. You have people who have COPD, okay, with FEV1 less than 80%, and either oxygen therapy, systemic steroids, or hospitalization emergency department visit, and no hearing loss prior to inclusion, normal QTc interval, no medication increasing QTc interval, and no medication susceptible of interacting with azithromycin. So take all your COPD patients and count who are those who fulfill all these criteria. Again, I didn't try it, but probably not that much. And there are several other treatments that can interact with azithromycin. And if I had asked all of you to name these products before without showing you the slide, probably I won't have got lots of good answers, because from myself I wouldn't tell you all that. So you have to keep that in mind before you begin prescribing widely these agents. Cardiovascular risks, I would say that I'm going also to kill that study because there is a difference. You can see it on the graph. This is on the right, top right. This is the occurrence of cardiovascular events. When you look at the numbers, well, it's 1 to 2 difference. It doubles the risk. But when you look at the numbers, it's very, very, very small numbers. So, okay, there is something, but, well. So when you prescribe, you have to perform sputum microbiology to check if there are some non-tuberculous mycobacteria. That's one thing. ECG, audiometric testing. Check other treatments, those who are susceptible of interactions and QTC increase. So you have to do that. When you look at some editorials, you see that. You have to do that initially and then regularly every 3 months up to 1 year of follow-up. Who does this when prescribing azithromycin? Answer, nobody. And that could be a problem. Once you will have some, I don't know the English term, but cardiovascular death induced by QTC prolongation, it could be a problem, especially since these agents are not in the international guidelines. Pulse treatment with moxifloxacin, very, very interesting study, in which it was found, and I won't debate about the primary per protocol outcome. It was the per protocol, which was the primary outcome. But when you look at this, what you can find is that you had the biggest efficacy of the pulsed moxifloxacin on what was called in that study the secondary definition of acute exacerbations of chronic bronchitis, which you can see here, which was confirmed acute exacerbations of chronic bronchitis, excluding all other types of lower respiratory tract infections, while the primary definition was finally all lower respiratory tract infections except pneumonia, which I bet fits better with what I believe is an exacerbation in the real-life practice. So it was more effective on the secondary than on the primary definition, which could be a bit of a methodological issue. And the sub-analysis on patients with mucopurulent sputum was a post-hoc analysis. So again, it just tells you that there is a hypothesis there that you have to test, but it does not provide you with a firm conclusion as to whether these treatments are really specifically important or useful in these patients. Probably yes, but you have to test it, and this remains to be done. And that's probably why you don't find macrolides in the guidelines. I mean, in the main international guidelines that you can find, the old gold or the new gold for now. Now I'm going to go to the antioxidants, and it's going to be brief. We know that there are many, many consequences of oxidative stress in the airways and in the parenchyma of people with COPD and emphysema. You have here an illustration of this. Nice figure. We know that when you act on oxidative stress, ultimately you will decrease the resistance to steroids, because oxidative stress is one of the main mechanisms of HDAC inactivation. So they should work. You look at this meta-analysis Mark showed to you already, and you see that there is an effect. I put a big arrow because it's a small effect, so just to highlight it. And the main problem in that meta-analysis is that there is significant heterogeneity. Heterogeneity regarding many of the characteristics of the patients that were included, regarding FEV1, ICS, concomitant ICS, the dosing of mucoactive agent, the history of exacerbations, and so on. Which means that I believe that you shouldn't perform a meta-analysis when you have studies which are that different. I mean, there is no sense in that. But anyway, you have a small effect. Okay. You have big papers, small effect, but big papers. You have them here. 2 of them were published in The Lancet, and the last one in Chest recently. And these are the main results that you can find. In the bronchus trial with NAC is negative. But you can see that it's positive with a 21% reduction of exacerbations, which is not that bad. But in patients who should be treated by ICS and are not treated by ICS, they have the indication, they don't have the treatment. So what can you conclude? except that you have to treat the patients according to the guidelines before you test something else. In the second study, you have very, very nice reduction in the occurrence of exacerbations with a 44% reduction. This was performed in Hong Kong, and you also have nice effect on small airways function, but, well, the patient doesn't complain about that. And you have no effect on other patient-reported outcome, meaning quality of life, exercise tolerance, and dyspnea. So this is the latest, the last study we have. And the carbocysteine study, very nice study, 25% reduction in patients who should be treated but are not treated in China. So these results are not consistent. In the study which has been published last year in CHEST, the patients were treated correctly, which is nice. So you can't use, I cannot use this argument that these patients have an effect of this treatment because they don't receive the treatment that they should receive according to guidelines. This argument is not valid here. So I'm a bit in trouble, but I found something. This has been performed in Hong Kong. And the other study, which was very much positive, the PEACE study on the bottom of this slide, was performed in China. And when you look at studies on genes and predisposing genes in the COPD area, you find that antioxidants and oxidant-antioxidant genes seem to be much more important or have been found to be responsible for COPD much more frequently in studies performed in Asian populations. So maybe these are specific targets for these kinds of antioxidant treatments just because they don't have the same genetic determinism of the occurrence of COPD, maybe. So in other population, in more standard population in our areas, well, we don't have agents that are very effective. That's the least to say. So again, there are many research teams which are working on new antioxidant agents, but the results for now are very, very disappointing. Here is a review by Peter Barnes, the annual review on new treatments and the annual review on antioxidants. And when you look at this table, you see all the agents that were or had been developed last year. And when you look at what's becoming with them, you see that discontinued, suspended, nothing. So this is quite disappointing. I mean, there are lots of agents which have been studied, but, well, you don't find a really effective one. So to conclude, macrolides might be effective in some patients, undoubtedly, I think. But selection criteria should be very restrictive, might not be the good term. The idea is to be cautious. I mean, be cautious because you can have some real side effects which can be very severe, even if it's a very small number of patients, but very severe. When you die, is quite severe. So be cautious regarding the heart, the QTC, hearing, maybe. Microbiology, I think that the risk has to be explored in much more details, both for standard bacteria and for non-tuberculous mycobacteria. We don't know much about that, but there is at least a potential risk which has to be assessed very thoroughly because before we put these agents widely in our patients. And also be cautious with associated treatments because there are many interactions, even with the modern macrolide agents. Regarding antioxidants, well, mucoactive antioxidants might, again, be effective in some patients. First of all, those who have no other maintenance treatment despite indications. And especially in China or Asian populations, there might be something here in terms of susceptibility to COPD and to the effect of these treatments. And other antioxidants remain to be tested clinically, but before being tested clinically, they remain to be developed because those who have been developed are not tested anymore, mainly because of side effects. Thank you for your attention.